Anna Mulherin. I am the pharmacist on the panel, and my part of the presentation is called Let's Be Rational, the importance of daily multivitamins in PN. So multivitamins need to be given daily. Multivitamins and trace elements should be given daily with our PN regimens. And that means that one full dose of an age-appropriate multivitamin should be provided in every PN bag. We should start this from day 1 of PN therapy. And there are many reasons for this. And this is a recommendation that is supported by essentially all nutrition societies around the world. So starting at day 1 of PN therapy, even for well-nourished patients, and I put that in quotations because, our well-nourished patients are not typically the ones that will be coming in and requiring parenteral nutrition. And so sometimes they may not have a diagnosis of malnutrition. And the reason for that may be because, as we all know, as nutrition support clinicians, sometimes and very commonly, malnutrition goes undiagnosed. And so they may be considered not to have malnutrition, but they will still be at risk for malnutrition, or they could be malnourished and have ongoing deficiencies that we are not aware of. And whatever the underlying etiology is that has led them to require parenteral nutrition is, evidence enough that we need to be giving them a complete parenteral nutrition regimen, which includes daily multivitamin and trace elements. And this is also true even in patients who are on oral diets, supplements, and vitamins, with some caveats. But if they are, taking in oral diets and supplements and vitamins, but still requiring parenteral nutrition, then either we should reconsider whether they still meet requirements to continue PN. And if the answer to that is yes, then they should still get a daily multivitamin, of course, and trace elements as well in their PN. So I'm going to touch on shortages. We've all mentioned shortages, and I know that everyone on the webinar today is probably very familiar with shortages. But since the 1980s, there have been numerous disruptions in our supplies, not just of multivitamins, but basically every ingredient that we need for parenteral nutrition. And there are numerous reasons for this. And we continue to see more reasons that come up that can lead to shortages. So we're at continued risk for this to go on. It will happen again. And so we really need to be prepared and know, when is it okay to ration and when is it not okay to ration? Rationing multivitamins is never the standard of care, but it is something that we have to do in order to conserve supply in certain situations. So this should only be done during times of shortages. We need to also understand that when we do ration, that we are not giving a full dose of vitamins that patients would otherwise be requiring. And so what has resulted in this, since many of us have not even, we've been practicing during times where we have always been under a period of significant supply disruptions. So this is normal for us to, often not have adequate supplies of multivitamins. And we may learn in those situations in that environment of a shortage, and it's become commonplace. And so this is, periods of rationing and always never using daily multivitamins has become common. And there is a perception by some that this is okay and this is, normal practice. And we've always done it like this. And so that's how I was taught. And so I am going to continue to use ration multivitamins. But this is not an appropriate practice. This is not the standard of care. And the reason for this is that it can and it does cause patient harm. I'm going to present a case that I saw recently. This is a 43-year-old man that was previously healthy. He had a hiatal hernia, and he was admitted to an outside hospital for a routine and elective hiatal hernia repair with a Nissen. He had several post-op complications that started essentially immediately after his surgery. He developed an empyema and had to undergo a VATS procedure for that. He also developed a gastric and colon perforations that he had to return to the OR for. He also had a cardiac arrest at one point early in his postoperative period and also had to receive ACLS. Ultimately, he developed a gastropleural fistula that was unable to be repaired via EGD. And over the course of all of this, he had encephalopathy. And the assumption was that this encephalopathy was from his cardiac arrest, and this was all from an anoxic brain injury. About 2 weeks after he was initially admitted to the outside hospital, he was started on PN. So he went about 2 weeks without any nutrition during that time. And about a week later, or almost 2 weeks later, he was transferred to our hospital for a higher level of care with an ongoing gastropleural fistula and ongoing encephalopathy. So here we are a month out from his surgery when we took over care for this patient. So at this time, he did have severe malnutrition. And typically when you look at a patient who's been on PN, you may assume, well, they have had adequate nutrition, at least for the last 2 weeks while they've been on PN. And so you may not put them at risk for refeeding syndrome or risk for vitamin and mineral deficiencies. But I would say that is a very dangerous assumption, and that we should definitely dig into what patients are getting in their PN formula, as Shelby already mentioned. So when I did this, I learned that his PN formula did not contain multivitamins. And this was due to not due to a shortage, but due to the pharmacy just not having any. And they had previously had a shortage, and they've just been doing, ration multivitamins. And then they ran out, and this patient was on PN, and they just never restarted it. They don't do a lot of PN at their facility, and they just didn't give him any. And I look back at his other vitamins, and he was also not getting oral multivitamins or any other oral medications. And so this gentleman had no vitamins at all, basically for 27 days until we saw him. So once we saw him, we resumed his PN. He never did have to return to surgery, but he did get an abscess drain and a chest tube. He continued to have encephalopathy, but once we realized a few days after we started PN and obtained his formula from the outside hospital, we did treat him with high-dose thiamine, and over the course of the next several days, his neurostatus improved back to baseline. And we were eventually able to transition him to enteral nutrition. So we presume that this gentleman did have Wernicke's encephalopathy due to his clinical presentation and resolution of symptoms with his thiamine repletion. And unlike the case that Dr. Larson-Naff presented, this was kind of an atypical case where we don't, he's in the ICU. We can't really do full assessments like we would in ambulatory patients. And there are so many things in the critical care setting that can potentially mask patients' underlying vitamin deficiencies and trace element deficiencies that we should consider. So they're a lot harder at times to identify. So the takeaway lessons here are that daily multivitamins and trace elements in PN are essential. And we should always try to obtain previous formulas of patients' PN to assess their nutrition status and their risk of nutrient deficiencies. Please don't assume that patients are well nourished just because they're on chronic PN. or that they don't have a risk for vitamin and mineral deficiencies just because they're on PN. But really kind of dig into that formula just like you would for any other medication that a patient is on.
Be sure to watch for upcoming Channel One videos on nutrition and learn more from our esteemed colleagues. Have a great day.